All right, thank you everybody for joining us for the May 9th, 2022 Bench Talk Live. I'm Rob Weber, the Director of Communications and Policy for the Kentucky Academy of Science. And this marks the first time that I've opened a Bench Talk Live. So thank you to my boss, Amanda Fuller, for giving me this opportunity. Appreciate it, Amanda. The Kentucky Academy of Science is a statewide organization of professional scientists and people who support and value science. Our mission is to foster scientific discovery and understanding across Kentucky. We do this in a number of ways. We have publications, including the Journal for the Academy of Science. We have annual meetings, which is the largest professional gathering of scientists in Kentucky. We have outreach. We award research grants. We create connections among scientists across disciplines and across Kentucky's geographic boundaries. And of course, we host things like this, tonight's Bench Talk Live. So appreciate all of you for being here for this one. Before we begin, I want to mention that tomorrow is Kentucky Gives Day. That's a day of generosity in Kentucky where people support the nonprofits doing great work in our state. And Kentucky Academy of Science is one of the nonprofits participating in that day. So I did want to mention that, and I'm putting a link in the chat so anyone can check out our Gives Day page, learn more about our group, and find out about the ways that you could support our group, which we greatly appreciate any support we get to continue advocating for science across Kentucky. So now on to tonight's speakers who we're so fortunate to have with us. I'll start with Dr. Rachel Keefe. I talked with her while the General Assembly was still in session this year about some of the policy issues that lawmakers were looking at. And I was drawn into her story about how she spent much of her career in cardiology, but in more recent times has been drawn into serving in the front lines of the pandemic. And she has all sorts of interesting experiences and insights about this that makes for a compelling talk. So I appreciate that she was willing to come here tonight. To share her background with you, she is an associate professor of medicine with the Division of Environmental Health, and she is the director of human subject services with the Envirome Institute at the University of Louisville. Her research program combines her skill sets in basic sciences, nursing, community participatory research, and clinical studies. And I'm also thankful that she arranged for our other speaker to be here with us today, and that is Lauren Anderson. Lauren is program manager for the Envirome Institute and Center for Healthy Air, Water, and Soil. She specializes in leading collaborative teams through community-facing projects and clinical trials. I understand that one issue she'll touch on tonight deals with wastewater testing for COVID-19. It was through this kind of testing, I understand, that Louisville found out when the latest COVID-19 subvariant arrived and was spreading in the area, so they could get a better jump on that and responding to it. So I'm looking forward to hearing more about the ways that wastewater testing serves as an early warning system for communities dealing with COVID. So with that, I will turn it over to our speakers, whichever one has arranged to go first. The floor is yours.
So I'm going to go first. Okay. So thank you for the kind introduction and inviting us here. We were speaking a lot about our COVID projects a year ago, and I feel like, we're slowly transitioning a little bit on my end, more so than Lauren's end. I think we've kind of handed the baton over to the wastewater, and I think a lot of people are interested in the wastewater. So what I really want to talk about, and kind of what we talked about in the phone, Rob, you and I, at one point, is how did we get here? What have we learned? What have we learned from the pandemic that we will use going forward to shape science and policy and health in general? So I am an associate professor of medicine. I have a nurse practitioner degree, so I do clinical care, and I do basic science research, my PhD. And so that has morphed into transitional care or transitional research. And let me see if I can actually make this go. All right, so I work from the Envirome Institute. I had someone read my shirt today and say, what is that? I've never heard of that. So what we do is we look at how the environment in general affects health, right? So within our group, we study parts of the natural, social, and personal environment. Rob mentioned I did preventive cardiology. I looked at things like air pollution and tobacco. I'm actually trained in regulatory science, which for those of you in the science arena is very different than any other sort of science, because you're specifically typically trying to generate unbiased research to address policy. So this isn't the mechanistic type of research that a lot of people think about. But a lot of time policymakers have a question and they say, we need answers to this question. We want to address it with science. We need you to figure out the science. So sometimes the questions are driven by us and sometimes they're not. But what I will tell you is, we think the environment is a complex, kind of multi-layered thing that you have to understand. So think back, is it 3 years? Yeah, I guess 3 years now, 2 years-ish, sitting at home like everyone else, hearing about COVID-19 and thinking that, hey, I'm going to be able to work on my papers and write grants and get manuscripts published. And this is great because when do scientists get this kind of time? And I think everyone thought then it might be a couple weeks, maybe a couple months, what's going to happen? And everything shut down. And I got a call that Monday morning at 8 from administration at UofL and said, hey, we need you to come in. Like, there's this COVID thing. We need you. We need help. We now know that there's over 1 million deaths in the US alone. There's over 6 million deaths worldwide. This is kind of a heat map of the confirmed deaths worldwide. This needs to be taken with a grain of salt, though. There's a lot of countries that either don't test or don't report or have very different ways of attributing death to disease, such as COVID-19. So what I will tell you is I think this will continue to change over the next decade when people go back and do other types of research to understand. I really don't believe that most of Africa has had virtually no deaths from COVID. I have family in South Africa, and if you talk to them, it is quite the opposite. So, I think these are all things about COVID that we did not know what was going to happen. And part of what I want to touch on is that, when a pandemic breaks out, everyone kind of gets called in from different avenues, and we do the best we can. But I think all this information will continue to change as we move forward. So why did they call me? Why did they call the Envirome? Because I'm not just one person. Why did they call the other people we collaborated with? At the Envirome, there's a great group of individuals within the hospital systems and the medical systems and the School of Medicine that is really focused on treating patients, right? People get sick, you figure out new drugs for them, you figure out new treatments, you figure out how to fix them. We've never really taken that approach. We've always had a preventive approach, which is a very different approach from a lot of other medical type researchers that do clinical studies. It is not always well funded to do prevention. Community doesn't always look at, hey, I didn't get a heart attack till I was 90. You gave me 30 more good years of living. So it's not a very sexy type of science. It's a very underappreciated and underfunded type of science. But what we have done, because we have always focused on prevention, is we have clinicians like myself and other people, other translational researchers who really focus on how do we keep people healthy, not how do we figure out how to help them. So once COVID hit, we wanted to leave the medical providers to helping those. There's so little known about how to treat people. Let's leave the people who are good at what they do, which is treating people once they get sick, to take care of the hospitals and the people that are sick. And we can take resources and we can take our knowledge that a lot of people don't necessarily have similar backgrounds because you need these different pieces. You need people who know about clinical stuff. You need people who can develop the basic laboratory science to do the testing, right? Because we didn't want to burden hospital systems to do the testing for COVID either. And you know, we have the resources to do all these sort of things, and we're used to quickly looking through literature and making decisions in a very unbiased way to try and morph with everything. So that's kind of how we got to being pulled into COVID-19. Our group was, and then we worked very closely with the Center for Predictive Medicine to do all the actual testing of the of COVID-19. So we very quickly were able to prop up high throughput PCR for to look at active infection. And then we also were very quickly able to prop up antibody testing, and that's IgA, IgM, IgG. So we could look at different, we could look at S and N, which are different parts of COVID. So we could look at a lot more than you would typically get from a lab, but without drawing resources away from the treatment. So what I will tell you is what was our approach then. So there's some science out there talking about South Korea, and there are other Asian countries. Japan was actually very big on this. They would test, isolate, find them, quarantine them, and then retest them, isolate, find them, quarantine them. They had very stringent, you know, what they would call boxing in the virus, and this was early on. And they were able to control their numbers. Japan did similar things. And then if you were sick, there were very good support systems to take care of you and your family and be able to make sure you had food and things like that. There was also this little town in Italy, and I remember sitting in clinic and talking to one of the attendings about it, where they found the first person who had COVID because they were just testing everyone. It was a very small city, and they were testing everyone. They found them, and again, they isolated them for 2 weeks, tested everyone they had been in contact with, figured out who was sick, isolated them for 2 weeks, tested everyone else, and within like a month, they had gotten rid of COVID, and they shut down their borders, and they said, we're done, like, we'll stay open to us, but we will, you know, they were able to essentially eradicate COVID. So our idea was, let's test everybody, let's figure out who has this, in an attempt to, again, do this kind of boxing in. If people know they have it, and they can isolate, and then we can turn that information over to others who can contact trace and quarantine. Can we keep our numbers low? And again, we wanted to let those who are best at treating the individuals, treat the individuals while we did this. So we developed a multidisciplinary approach. Again, I kind of mentioned, you know, we worked with basic laboratories so that they could stand up the testing we need and not pull resources from clinical sources for those who are sick or needed it. We also designed methods and looked at testing methods to figure out how to do random sampling, because we knew that we may be introducing bias. How do we select our cohorts? Who do we work with that gives us the most information? How do we reach the community? How do we talk to them? Because I think a lot of people forget that there's, I think, unfortunately, a large portion of scientists who do not focus on communicating with the lay public and people outside of their profession. So, you know, me talking to an engineer is a very different language. And so if I only use the scientific terms and try and make sure everyone knows as much as I can, that engineer, who's also very highly educated, will have no idea what I'm saying, let alone my mom, who's not a scientist. So we really have things in place, people like Lauren and other groups who do a lot of community outreach and look at the language. We have a lot of established ties in the communities with diverse partners to bring in stakeholders who might be minoritized or not have the opportunities to access healthcare the same. And then, you know, we have the ability to ask people questions to figure out about, you know, what do you think about vaccination? What do you think about testing? Why aren't you testing? Why are you testing? and do all these complex modeling approaches. So I'm going to do a sidebar here. You know, everyone involved in the project, the university, the city, the state that we were giving this back to, did a lot of, we're very excited about this because it was going to be truly a randomized study of testing. But at the same time, we had a lot of people very angry at us. We had a lot of people thinking that we were, you know, taking away from the sick, taking away from other populations. We were trying to shut down the city, which actually we were trying to not shut down the city, but figure out how to isolate people so that the city could stay as open as possible, and, you know, keep the infections down. We were trying to potentially save populations from overrunning hospitals, which would help those treating it, but instead at times we were called murderers and other lovely terminology for doing work that we were asked to do by the CDC, the city, and the state. Just normal scientists kind of trying to regroup and repurpose into something that could be helpful. So it was not, though many people thought it was a great thing, it was not always, it was a very dichotomized reaction that we got. So the project we had was for the community project. We had 3 arms. One was for hospital workers. It was the first one we did so that they would know if they had antibodies, they would know if they'd been sick, and we could start to get an idea of who was getting sick. And at the time, we found out the people in the ED, ICU, and COVID floors had the highest rate. So over a third of them, towards a half of them. And this was very early on. This was in April, had already been infected with COVID. And a lot of them didn't know they had been. Then we moved on to the community itself, the wider community, to start to get those numbers for individuals and to give people an access to the information they needed. And then we've moved on to a long haulers project. So really fast, you know, part of what we did was take some of the epidemiology we do and did a random sampling of Jefferson County to get the best rates. You know, there's a lot of fighting about what's the best test, you know, who should test, why should you test? And we kind of just wanted to go back to science and not get involved in the politics of everything or the finances of everything, and say, you know, you need a random sample. If you don't have a random sample, you're going to introduce bias. And we need to know true numbers so that we know how many people are really sick, how many people may be protected by antibodies, who needs help. So we worked with Westat, who does the NHANES project, if anyone's familiar with that, or other large national recruitment strategies, where we would sample from 8 different, we broke the city up into 8 sectors, and we sampled proportionally what the makeup of the race, gender, and age and ethnicity of Louisville was. So that way, when we brought people in, what we could do is we could create more realistic models of how many people in the city would have been sick based on your age, race, ethnicity, sex, those sort of things. And we weren't only drawing people who were super conscientious and trying to screen a lot, or we weren't only drawing in people who were sick. So we worked with a lot of community engagements, and I think this is something that scientists don't always do very well when we're tucked away in our benches and our other places. We worked with Churchill Downs to get to the Hispanic Latino community. We had to bring in translators to work on site with us. We had to deal with cultural issues about testing or about when to test, times of days based on work schedules. We had to have the translators. We worked with Neighborhood Place. We worked with the Louisville Urban League. We worked with TARC. There are a lot of businesses who wanted to shy away from this. We heard from some businesses that they said, you know, they wouldn't let their employees test because they didn't want to have to shut down. So they would rather people come in and get sick, and then they would deal with it then. But there are other businesses that were very interested in testing. So it was a very dynamic thing. And I want to really thank Louisville Urban League, MSD, a lot of these community organizations, because a lot of this was done during the same time that we had some of the racial justice and equity marches going on and some of the shutdowns of the city during that time. And we were, these, you can see where all our study sites were. We were in areas and parts of town where the marching were going on. We popped up sites, there were gunshots. We popped up sites and had all kinds of interesting things. We would have to put up generators, we would have to put up tents. We had to find people who would work. Some people, didn't feel like being basic. Coming from the sort of research that we were, they weren't really healthcare workers. So it was one of those questions too, can you mandate staff to come in? Can you not? We're not truly healthcare workers. We're not a hospital, but we need people with a healthcare background to do the testing and things. We also were able to work in a lot of efficiencies and provide those back to health systems or other diagnostic companies, because we had academic partners in other areas who could let us know about systems like Primary for testing and things like that. So I want to just highlight the fact that, as community-based research, you have to go into the community, and the things that they don't teach you in school about science, or how to start generators, or how to build tents, or what sort of resources you're going to need in the field. This is the sort of data we were able to give back. So we could give positivity trends. We did about 8 to 12 cycles of testing on people, so we could show over time how positivity rates were changing, how antibody rates were changing. We could map out prevalence rates. We can map it out, again, based on these factors like race, ethnicity. So we were showing that in Louisville, Hispanics had about Hispanic Latino individuals had about twice the amount of COVID as the white population. We found that minoritized communities were struck very hard early on, and then when the city could divert resources for campaigns for testing and things like that, they were able to bring down their numbers in their community of COVID. We saw that there are a lot more people infected than they thought they had been. So our rate was typically about double, if not more, than what was reported by the city. And again, we were able to find asymptomatic cases of individuals who maybe weren't able to test or didn't have access to tests. We looked at environmental factors. So if you went to work, you were more likely to get it. If you were doing things like masking, you were less likely to get it. But living with others or kids or things like that didn't really do anything. We were able to look at tobacco and COVID. So we saw that fewer people who use tobacco presented with COVID, but if you did present with COVID, you were actually typically a lot worse off. So there were these contradictions that we were able to use national data sets like the AHA guidelines to start to tease out more information, and then feed that information back into the basic science pipeline to think about, is it ACE? Does nicotine interact, with ACE? And is it blocking, or is it altering the antibodies in the nasal cavities in the mouth, which is where, is there more mucus there? So, the infection can't get in, or, and to feed those questions back. And people are now all working on the science behind those to help with future pandemics. We also did a lot about vaccine hesitancy. So again, we are a very diverse group. We found out that only 31.5% of minority participants even knew how to sign up for vaccinations early on. We looked at the sources that they were most interested in. Anyone was most interested in receiving information about the vaccines from, to help the city and the state figure out campaigns and programs to do. And we also talked about hesitancy and tried to find out why people were hesitant with vaccines, to see if there was any sort of information we can provide back to those who are encouraging that as a form of prevention. We also have gotten to the post-acute COVID syndrome world, or PACS. Early on, people didn't really think long haulers was real. Providers themselves were somewhat not very thoughtful in how they treated patients presenting with this. Researchers didn't always believe it. But when you look at the history of viral diseases, post-viral syndromes have been going on for a very long time. And a lot of people think Epstein-Barr is actually a post-viral syndrome, and that a lot of chronic fatigue is actually a post-viral syndrome. And so there's a lot that we're starting to do and work with to look at the clinical side of it now and see what's going to happen moving forward. And we can look at vaccine rates and the severity of disease based on immunophenotyping in people to see if any of those are linked with these PAC syndromes. We can look at the vascular. So it's a lot of interesting research coming out there. But this is the part that I think is most interesting for me. So what does it mean for the future? What are the next steps for scientists? Because I am convinced this is decades of fallout still for science and society. So, going back to our mission at the Envirome, we want to look at the personal environment. So Black males were hit really hard in this pandemic. And so, what does that mean to individuals who lost loved ones, what does that mean to someone who identifies as a Black male versus someone who doesn't? How does your race and your biologic sex and your predisposition to disease impact your experience and impact what comes out of this? People weren't able to go to the gym, or some people had a lot of time to work out. What is that going to mean for people? Will some people just never go back to working out? Will that impact their health? I think we hear more and more about the economy and mental health. This went on a lot longer than any of us anticipated in the beginning. So what are the fallouts going to do for that? There's a lot of people leaving the healthcare world. So what does that do for those people who still need care for other things like heart attack or COPD? How is their health and their quality of life going to be impacted? And then vaccinations and the kind of the politicization of science. That's my biggest thing. And I feel like that falls on social and personal. So it's kind of a good segue over to social too. This pandemic was politicized in a way that I have never encountered before in any other sort of area that I work in. And, the environment isn't always a fuzzy place to work in science. So the fact that this is so much worse to me, and I think this is some of the conversations I've had with people, is it's really made me think about, as a scientist, what do we do moving forward? Because I think most of the scientists I know are truly unbiased. We don't have an agenda other than learning and educating and making all the information we can to make things better. So how do we unpoliticize science again? And how do we teach people to understand what we do as a profession and understand that, we don't find the answer the first time and things do change and morph. And, that's one of the things that really made people mad in the pandemic. Like, you just told me a week ago I didn't have to wear a mask. Now I have to wear a mask. Now you say these masks are okay and these ones aren't. Like, how do we talk to people about science and that we're always learning and evolving and flexibility? But other than that, think about food chain supplies and supply chain, and how do we think about where our food comes from and how we get clothes, and our social systems that were kind of shut down, schools and religious institutions. So all these sort of things, including with the natural environment, pollution really affected people's likelihood of getting COVID, and then the outcomes of COVID. People actually moved to other places to work because it was easier to work remotely. A lot of people stopped driving to work. So is that going to impact climate change? If we don't have the supply chain moving things around as much, will that? There was also times when people were dumping things in the field because they couldn't move it. So, and then the masks, please tear your little ear loops off your masks. That's very nice for the ocean if you do that, so animals don't get caught in it. But these are all things that I think, over the next 20 to 30 years, we're going to need a lot of science and a lot of education and a lot of thinking about how we talk to people about science, how we think about who the stakeholders in science are. Is it really just us doing it, or is it really the community and the lay people? And, how do we get information back to them faster? How do we communicate our unbiased nature in general? how do we also talk to them in a way that's not belittling, but also is very accessible for all to partake in science? And so these are all things that I think the Envirome and other scientists need to keep in mind as we move forward. So this is a laundry list of people, and not even everyone's here who participate in the community. We have to acknowledge our donors and our sponsors and the CDC and all that for funding. So without ado, I would like to move on to Lauren, who can, like I said, this was kind of the background. This set it up. This was really the meat and potatoes for a year or so. We saw over 25,000 people in the community project total. It was a big, big thing. But we know, kind of like that social aspect of things, people's appetite for testing and people's appetite for staying home, and and people, it has gone down, and people are more aware of variants. So they want more information. They want to know what variants are in place, and when are they here, and what does that mean? So I think wastewater has kind of picked up the baton from us in a lot of ways. So Lauren can tell you a little bit more about that.
Thanks, Rachel. That is a good segue, and working on sharing my screen. And I believe everyone should be able to see that now. All right, so I'm Lauren Anderson. I am also with the Christina Lee Brown Envirome Institute at the University of Louisville School of Medicine, and I also represent the Center for Healthy Air, Water, and Soil. So you can imagine how that fits in with our whole portfolio of work. And so just like Rachel was mentioning, there are limitations of individual testing. So if someone doesn't have symptoms, they might not know that they need to go get tested. And so, testing everyone can miss those asymptomatic people. It's really resource intensive. It takes a lot of money to stand up all of those testing centers, to staff them, to process the results and communicate those results back to individuals. So, there's an article right there that it can cost a whole country a significant portion of its overall GDP. And it is also dependent on the public's sense of importance. So just like Rachel said, we don't really have an appetite for testing anymore. In fact, whenever JCPS stops its testing, whenever they release the school year, that's basically the end of any testing plan that's happening here in Louisville. And that's fine. And that's where scientists like the team that I work with can jump in. We also have the ability of at-home tests. So even though people aren't going out to get tested, they can still protect themselves. And if they are having symptoms, they can know if they are sick or not. But unlike getting tested at a facility, those results aren't tracked, they're not communicated. And so we don't have that big national picture of what it looks like for everyone anymore. And then that sort of leads us to the next one. There's lack of shared reporting frameworks. So we don't have systems that talk to each other. And that just means that we are making decisions a little bit more in the dark than we used to. And so that brings us to wastewater-based epidemiology. So this is a scientific method that can sort of fill that gap. And so what wastewater-based epidemiology, I'll also use sewer monitoring or sewer surveillance, any of those type of words, but it really just involves taking pooled samples from a sewer system, looking for specific biomarkers, chemicals, you name it, it's in the sewer, and then analyzing those results from defined catchment areas that are associated with groups of people. So this is not a new technology. So it was first really discovered in 1854 when John Snow, who did know quite a bit of things, figured out that a cholera outbreak in England was being traced back to a well next to a laundering facility where feces was entering the water supply. And so that has been used, for a few hundred years to do things like eradicate polio in different countries and also track the use of illicit drugs. It can be used basically to find anything. Why we were down in the sewers to begin with is looking for urinary metabolites of air pollution. So whenever the pandemic hit in 2020, we were really lucky and fortunate to be able to do a pivot and start looking for evidence of viral material instead of those metabolites of air pollution. And so coming into 2020, the University of Louisville led the application of the sewer monitoring as a partner to both Louisville Metro Public Health and Wellness and to the Kentucky State Department of Public Health beginning in 2020. And so the initial focus of these partnerships was just on quantifying the amount of virus in community and correctional settings and to help inform public health officials about intensity and spread of infection. However, by February 2021, that work expanded to include the full genomic surveillance so we could recover these viral RNA fragments and arrive at estimates of different variants that were moving around in our community. All right. So there's different scales for wastewater-based epidemiology. And so they vary in numbers of people that you can track or know about using them. And so this is the 3 scales. There's congregate living facilities. So that counts anything like senior living facilities, different campuses, jails. And so this method, the scale measures hundreds to thousands of people. We did not monitor at this scale here in Louisville. We were monitoring some senior living facilities and jails across the state, but not here in Louisville. We were more on the neighborhood and city scales. And so on the other side, you will see 2 maps of our sewer shed areas. So that middle is the neighborhood scale. So collections of neighborhoods or neighborhoods. These measure thousands to tens of thousands of people. So our smallest one is right at 8,000 people. So whenever we were questioned with, like, you know, these political arguments, are you spying on me through my wastewater? It's like, no, I'm not. I kind of am. I'm spying on you, but also 8,000 of your closest friends. So like, I hope that's okay. But then you can also go up to the city scale. So we can measure, you know, up to 350,000 people that contribute to that Morris Foreman Water Quality Treatment Center that you see sort of just below the river. And so site selection. So we used a stepwise approach to figure out how we would construct all of those sewer sheds that I just showed you. And so we looked at an entire picture of Louisville, and we looked at infrastructure and socioeconomic data. What that means is we looked where the roads were, we looked where the sewers were, and where those manholes were. Then we looked to see where the people are. And so we prioritized residential areas and we minimized industrial areas. Whenever we were monitoring sewer water, we didn't want hundreds of thousands of gallons of hospital waste, because obviously that would send up a different signal than we would want, because we would be prioritizing the sick individuals who would be in the hospital. So we really wanted to get that really great picture of what was happening across the city. And we wanted to make sure that we included all the water quality treatment centers. So if in those smaller neighborhood catchment areas, some folks got left out, they would be counted another way. And then finally, we assessed feasibility. So we couldn't have sites that, you had to have a 4-wheel drive truck to access. We couldn't have, a manhole in the middle of Broadway because there's traffic there. And so if there were safety considerations, we would throw a site out. But ultimately, we landed on 17 different sites. And those are here. And so you can tell that basically the entire Jefferson County here is accounted for. And so 9 of those sites are manholes, like you can see in the top image, and that's one of our partners from MSD who is actively pulling a sample. So you can see that composite sampler ready and waiting on the ground. There were 3 pump stations and 5 water quality treatment centers. And so this helped us see how different areas of town relate to each other, and just for experimentation, where should we test to get the best picture of what's happening in Louisville? So since then, these 17 sites have been trimmed down to 8, and we're still getting the same quality of information out of those sites. And so going on to field methods, there's a few different field methods. There's grab samples, which is least representative of an area population. Like you can tell on the picture, you sort of just drop a little cup into the sewer and pull out whatever is there. So you get really just a snapshot in time. The kind that we liked a lot is a composite sample. It's more representative of an area population. And so what's happening underneath this MSD field technician here is there's a composite sampler, which is really just a fancy pump. So that fancy pump is pulling water from the sewer every 15 minutes and filling up that large jug inside that composite sampler. So he's doing quality testing right there to make sure that everything is the right temperature and it's looking great there inside that big jug. Then once he ascertains that, he would fill up those smaller jugs, and then those would be, or the smaller bottles right there, you can see 4 of them, and then those would be transported over to our lab. And then again, a treatment plant sample. So we pull water from the effluent. So when water is entering that treatment plant before it gets treated. And then we just have a great idea. That's also using a composite sampler. And so we have a good idea of what has happened in the past 24 hours for that large area. And so this is what it looks like when we assess the raw data. So right here is SARS-CoV-2 RNA. So that is the virus that causes COVID-19, and a specific type of DNA, we'll call it N1. And so this is normalized by flow across Louisville Metro from August 2020 to October 2021. So the scatter plots represent this raw data, and then we fitted lines to it. But unless you are deep in the science, this probably doesn't mean much to you. And so then we engaged in a lot of research translation. So since February 2021, we have been sending weekly updates as an academic partner to Louisville Metro's Public Health and Wellness, where we graphically represent the levels of N1 and presence of wastewater variants within this rolling 4-week period. And so you can see from June 28 of last year how we are sort of on this roller coaster ride all the way up to May 2nd of this year. So I'm really interested to see what this graph will look like this week after all of our Derby festivities. So it'll just be really interesting. And then you can see at the bottom, we also have a chart so we can see where in Louisville might be driving some higher numbers. So for a few weeks ago, you can see that Morris Foreman had the most viral material recovered, which is not surprising. It is the biggest area, but it's also leaps and bounds more than the week before, which was highly concerning. This is a lot of BA2 taken off here in our community. That's what we're seeing here. And so not only did we just provide folks with the amount so they can compare in time with what is happening now versus a month or 2 ago, we also want to track clinical markers using frameworks like the CDC's risk guidelines. So right here, you can tell how the CDC arranges risk. We have translated that over to our graph. And then that smoother orange line is those clinical markers. So those are new hospital admissions. The blue jaggy tooth line behind it is the actual wastewater data. So from here, you can see a few things. You can see the trend, and then you can see that the new admissions from these hospitals track pretty closely with the trends in wastewater about 2 weeks after. So the idea is that we can use wastewater as an early warning system. So, if we see this wastewater start to spike like we were, just a few weeks ago, then we might be able to inform the health department that you should maybe consider advising the hospitals to bulk up staffing or just have some plans in place. And so the same idea flows to bed occupancy down below. And so we have also noted variants that have been observed in smaller wastewater catchment areas, that's happening in street utility lines, but not uniformly observed at different treatment centers. And so this is one of the benefits of these sampling designs that are locked in space, is that it allows for geographically precise identification of neighborhood spread. So for instance, this is the summary from a few weeks ago. So we had detected all BA2, which is happening across the United States, especially in the Northeast right now. And so you can kind of see it flow in space from the upper Midwest down to here. And so this was also the first week that the new variant that we're hearing about in the news started popping up. So that's the BA.2.12.1 variant, and it has some additional mutations as well. What is interesting about this wastewater and this virology that we're doing is we can see in real time how these different variants, flash in a pot and then go away, and then they'll flash in another sewer catchment area a little bit later. And so while, let's see, 50 degrees. Okay, so that new Omicron variant was in all of our sites, all 7 of them except Preston and South Park last week. And now it is only in 2 places. So, why that is, we don't know. And so, this is what's exciting about science. What is it that makes some areas susceptible while others aren't? Or why does it pop up in one place one week and go another place the next? And so this is also helping us to inform what we're calling wastewater screening and clinical confirming. So during our initial 4 months of genomic analysis from February to June 2021, there was a loose coupling that emerged between wastewater and clinical surveillance. And this provided us an excellent opportunity for some shared learning. So because wastewater testing is a form of pooled testing, we really are sampling 100% of the people who are contributing to that sewer shed. And so it's more likely for us to detect an emerging variant in wastewater than through these nasal swabs, especially since we're not getting as many anymore. And so this was first demonstrated in April 2021 when we identified the Gamma variant for the first time and then communicated that to the county and state for a public health response. The variant was later confirmed by a clinical test 1 week later when within that same wastewater catchment area. And then since then, there have been a few different comparisons between catchments and clinical trends. So we found another variant that did not rise in the media as the others did, so you might not be familiar with it, but we found the R1 variant. We found another B variant in September of 2021, and then right before Christmas of last year, we found the Omicron variant here in Louisville. So let's see, there's a video here. And this is another really great thing that our genomics core can create for us. And then that just shows how the intensity of these different variants across time and space. And so the data is down below, and then as the shades of blue get darker, it means that there's more of this Omicron variant in those particular sewer sheds. I'm gonna just speed it up for time. So it was very light for a long, long time. And then by January of this year, Omicron was everywhere, which we all remember. But just like Rachel says, there is scientific fallout that can happen for decades after this. So what does this all mean? We just don't really know yet. All right. And so an important part of all of this work we're doing, I alluded to it earlier, is research translation. So it's great that we can pull all of these samples out of the sewer, but unless we are doing good with it, unless we can help people, there's really no point. And so one of the things that we wanted to know is how aware and how accepting are people of sewer monitoring. And so not surprisingly, there was low public awareness for sewer monitoring for COVID-19, and there was strong support for the public disclosure of results. People wanted to know what we were pulling out of the sewers, and you can't really blame them. Because of that, we set up a wastewater dashboard. So that variant chart and those clinical marker charts, anyone can see on a weekly basis. That is also pulled over now to the health department's data tracker as well. So we're making sure to share these results. And the most support was at the largest spatial scale, so more than 50,000 households. And people who had COVID before were more likely to support really localized monitoring, maybe at the neighborhood or at the campus level. We repeated that survey in a national survey as well and found a lot of the same results. But we're not stopping there. So we have also started the Kentucky Public Health Laboratory Wastewater Collaborative. So this is just a network for any lab, commercial, academic, public lab, who is engaged in wastewater-based epidemiology across Kentucky. So we are busy sending folks to different labs so they can learn different processes. We are training the state in how they can reach out to different rural wastewater treatment facilities and depoliticize the message of what we're looking for and why it's important. And then also we have research collaboration opportunities. So we're not the only folks who are doing this. Latin America and the Caribbean region have recently started their own wastewater collaborative. So hopefully we get to visit them whenever travel is safe again. And the other side is an example of what some of our collaborators are doing. So over at Murray State, those folks are looking at rest areas along the state highway to see what is in those sewers afterwards. And so, of course, I do have to acknowledge all of our collaborators and our funders and, the Center for Predictive Medicine and the Genomics Core, Bioinformatics Core for processing so many samples for us and really giving us some great information. All right. And from there, we can answer any questions that you might have.
I have a question. Thank you so much for all this. It's so interesting. And I live in Louisville, so I was hearing the news and hearing the controversy that Rachel alluded to. So it is interesting to hear you all tell that story as well. Lauren, I wonder if you could go back to the slide that had the clinical tracking, where it had the wastewater data and the admissions to the hospital and the, I can't remember another clinical indication on that. It looked to me like in February, there's a divergence, like those track pretty well until about February. And I wonder if you have any insight into what's happening in the data in these recent months.
So that's the Omicron, right? That's about when Omicron hit.
So it seemed like the detection, yeah. So the detection of the N1 was going up and the new admissions were going down and the bed occupancy was going down. And so does that just mean that it was a less harmful clinically to people? Is that what that's indicating, even though it was?
So I'll answer that. I'll answer that question for her. We, and this is what people hate. This is part of why people hate us. We don't know because there's two things going on, right? We think Omicron is less clinically speaking, less severe, right? Like we do think that. But at the same time, we also know there's a lot more people who are vaccinated. There's a lot more people that have had it. So we think there's these two things converging at once. So, what proportion of it is that Omicron's that much less severe, and what proportion of it is that there's that many more antibodies going around? We don't know. But what we do know is antibodies don't always, this was one of these communication things we really struggled with in co-immunity, because people are like, I got my vaccine. How could I have gotten sick? Vaccines for this particular virus are not to keep you from getting sick. They're to keep you out of the hospital. And antibodies for this particular virus, because most people had antibodies from a different mutation, right? They don't keep you from getting sick per se, but they keep you out of the hospital. And that's what this data is showing. We just don't know which, we haven't tried to tease out proportions of, where it's coming from. But again, that's why people hate scientists, right? We don't give a straight answer. We don't
But
give
it's
a
a
yes or
powerful
no.
message. I mean, if what you're saying is like, here's the evidence that it's keeping you out of the hospital, like that's a really powerful message, so maybe that's something that we need to double down on.
Yeah, it is a very powerful message. And there's a lot of powerful messages with the science, if you look at the science and you look at how you interpret it. But at the same time, the same powerful message is being spread too, right? The message is, well, look at all these people who got vaccinations, but they're getting sick. So why would I do that? So you can have two sides of one coin. It's just kind of where your perceptions and your beliefs are coming from that are driving which one of those messages you're tuning into, right? And that's part of what we look at too, is how do we get people to look at the science a little more objectively instead of listening to it only with an ear for a message. Does that make sense? Like, how do you understand the science itself instead?
Right.
Thank you for that. That was a great question.
Any other questions? I do have one. Dr. Keith, you mentioned vaccine hesitancy and laid out some of the reasons for that. I just wanted to see if you could tell a little bit more about what you think it might take to best overcome that hesitancy.
Yeah. So, I think there's different things that are going to overcome hesitancy. I mean, time always helps. I do believe that. I don't think vaccine manufacturers are going to put a product out that, does a lot of these crazy things that have been, potentially hyped in the market. But unfortunately, Johnson & Johnson has been kind of saved for people who won't do anything else now. So I think time will help us, because I think people will get more comfortable as they see people not getting sick from the vaccines themselves, or we just looked at, okay, well, I can get COVID now and I'm not going to be in the hospital, or maybe I don't have to worry about long haulers, or, maybe I'm not going to be out and down and not able to help my family members. Because I heard stories, of that, even people just were so sick they couldn't help other people in their family who were sick too. So I think time is going to be helpful. I think, again, to me, this has been, I think scientists need to communicate better and more and think about how we communicate. Our channels of communication, like get on TikTok, get on places where the people are saying they want to hear information or they're getting their information, right? We can't continue to do things the same way as we used to. We see too many people drawing information from sources that science hasn't utilized as well. I think not being afraid to do a lot more multidisciplinary, multi-institutional, multi-partner research is super important. And I think these efficiencies that both Lauren and I alluded to are very important too. You need to be able to do larger scale research than we've done in the past, so that you can include more people of different backgrounds, different socioeconomic backgrounds, different racial backgrounds, different ages, for those people to feel like they're included in the research and they're really represented. So I think there's just a litany of different tools, but it all, to me, goes back to educating people at a young age of what is science, how does it work, how do you understand it, is helpful for anything moving forward.
Thank you for that. One last call for any other questions.
Yeah, I've got a question.
Yep.
The testing you were doing, I assume, PCR tests primarily on the wastewater. Is that correct? And if so, were the PCR tests, were you also, there are two questions. Did you purpose build PCR tests for looking at wastewater for COVID-19 and its various strains? And number two, were you seeking to identify other human respiratory pathogens in the samples that you were analyzing?
Great. I'll answer the second question first. So we are not at the current time looking for other human pathogens. Like I mentioned earlier, we were there looking for urinary metabolites of air pollution. So that work will continue. And in addition, the CDC has a list of a few other respiratory viruses, and we have partnered with the health department and JCPS for another list of some vector-borne diseases, diseases that come from ticks and mosquitoes, different biting things, and different GI issues like norovirus that keeps kids out of school. So, if we can use wastewater-based epidemiology as an early warning system for hospitals in a COVID scenario, could that be also useful as an early warning system for schools to prevent some absenteeism? So if we know that there's an RSV breakout or a norovirus breakout, how could that information be useful to the institutions that need to know that, like JCPS or the hospital systems?
Do you want to answer about PCR?
I would love it if you would.
Okay, so yes, it is all PCR based. So it's very similar. We look at different sections of SNN, but it is all PCR based, very similar to what we would do in the human population in their specimens for PCR and their nasal swab specimens, because we wanted to be able to do correlations between the two populations. So by taking that random sample and getting what we believe is a truer prevalence, and then the data we could just get from the city and combining the city's data with our data with the wastewater, we felt that helps supports the modeling behind understanding the wastewater. So it is PCR based. And then for the humans, we also did antibody based testing just in case, to look at prevalence through antibodies and PCR, but we didn't look at any of that in wastewater.
One of the slides inferred that you also did unbiased gene sequencing. Is that correct?
So I believe.
Were you sampling all samples, or I assume you were just sampling, if you're doing unbiased gene sequencing, a certain subset of that population, and if so, how did you come to determine what samples that you did perform unbiased gene sequencing on?
So we have partners within UofL who did that. What I can tell you is this. So I won't have the exact answer. I would have to get back to them. My understanding, and it could be wrong, was that with the wastewater, it was much easier for us to do every sample in an unbiased, genomic way. So we were able to do that in a lot of the samples from a certain date. And that's what I can't tell you. I don't remember what date we started doing the large scale genomic, because they have high throughput platforms where we could do that. And then we would take a random sampling, or if there were certain people that they wanted out of the studies, they would do more of a random sampling with the individuals, because again, we would have thousands of samples versus 18 there. But what I don't remember is what date we started doing the larger high throughput
February
measurements?
2021.
Okay.
Is there a final question? All right, well, thank you so much for the speakers tonight and being so informative. As you mentioned, so many of these issues are things that people don't know enough about. So thank you for making us among the fortunate few who have learned more about them tonight. It has been interesting. Thank you to everyone who tuned in. I'll give a final reminder that tomorrow is Kentucky Gives Day, the big day for supporting nonprofits. So everyone here with an interest in science, we hope that you'll consider making the Kentucky Academy of Science an organization you support on Kentucky Gives Day. And the link is in the chat to our fundraising page. And also in the chat, you'll see a mention of the upcoming Bench Talk Live that's going to take place on Friday, May the 20th. That will be with the Geological Society of Kentucky, and the subject will deal with the geology of the Ordovician hybrid group. So look forward to the next Bench Talk Live. Thank you so much for tonight's presentation. And with that, I thank you all and sign off.
Thank you.
Thank you much.